Hi, welcome to Thoughtful Planning. I'm Honey.
And I'm Santiago. Remember, this podcast is for informational purposes only. For professional advice, please reach out to your doctor. So, as always, we're going to start with an essential question. So, today's essential question is going to be, how do you know if hospice is good for you or your family?
That is a great question, babe. And we're in luck because today we have a special guest, Robyn Cogburn. She happens to be our neighbor and she currently owns Crafted Sustainable Wellness here in Boerne, Texas. Recently, I was chatting with Robyn and I mentioned how we started our podcast on planning for end of life. And she told me how she used to be a geriatric nurse practitioner and her experience with the talks between the patients and their families. And also, she shared a bit about hospice and palliative care. So, without further ado, Robyn, will you please share your background with the audience?
Hey, I'm Robyn Cogburn. I graduated from nursing school in 2008. After that, I immediately went on to grad school. I became a nurse practitioner in 2013. I practiced in family practice, except for we were a very geriatric heavy practice. And I pretty much saw patients only over the age of 65. So I worked in a family practice clinic for about 10 years, actually 10 years. After nursing school, I went to grad school at West Texas A&M. I graduated with my nurse practitioner in 2013 and spent most of my career at a family practice clinic that specialized in geriatric patients. So I saw patients in the home, I saw them in the hospital, I saw them in their assisted living, anywhere that they were, I went out to them to provide primary family care.
Okay, fantastic. I couldn't imagine being a nurse. When I see blood, I get all, but,
Yeah. People
but
don't bleed very often.
yes,
Like,
well,
believe it or not, there's not much blood.
yeah,
Wow,
well,
interesting.
Yeah.
that's interesting. So, can you share the difference between hospice and palliative care and give our audience an example of each, maybe a story?
Yes. So let's start with kind of like what they are. They're not necessarily a specific junction. I think of it more as like a split in the road. So at some point, we get to the road and we understand that the person has the body that they have is not going to continue to function much longer. So for whatever reason, they're not going to function. And so at some point you have to decide, what road are we going to take? Are we going to be really aggressive? Are we going to just be hands off? Are we going to focus on mental and family health? So what is our goal? And so one of the ways that you can go down is the typical healthcare route. Most of healthcare is like the majority of healthcare is spent in the last 2 weeks of life. So you can do that. You can go to the hospital. You can stay in the ICU. You can die in the hospital. That's just a totally good option to maximize, everything that modern medicine has. But it's just not the only path. So there are other paths, and I would start with palliative care first. So palliative care is when we start to realize that this body is not going to make it. And this is just a natural progression. Death is just a natural progression of life. So we get to the point where we realize that. Now we decide, do we want to be aggressive or do we want to go a different way? So if we choose to go a different way, we have hospice and palliative care as options. So I would first start with just talking to the family. And if they choose to do palliative care, that would be something like a patient who has COPD and has diabetes and has a couple different things. And we don't have any specific condition that we can diagnose and say this is what's going on. So if their body is just failing, we can say, what do you want to focus on? And so palliative care gives the patient and the family leeway to make decisions. So if something came up and you're on palliative care, a great example is urinary tract infections. So if you get a urinary tract infection on palliative care, that wasn't going to cause your death. It could cause your death. And so we would treat things like that. We may do surgery, because if a surgery would reduce pain, then, let's do that. Let's go do a lobectomy in the lung if, it's causing pain. So we can do procedures and surgeries and treatments that help relieve suffering. So we kind of can do a mix. We can do medical treatments if we need to. We can also step back and realize, if we go to the hospital, it's for the UTI. If we go to the hospital for the UTI, they're going to get better, probably, but they're also going to stress out and be really depressed. And so depression decreases longevity. So if you discuss at that moment, is it worth it to send mama to the hospital to get the treatment for the UTI, or is that going to stress her out so much that she would just rather stay at home? And so you start to have those discussions. Hospice is more of a, I'd say even legalish, more of a legal term. So, first of all, palliative care can be given any place that you are. Palliative care is not a facility. There are facilities, but mainly it's just the path that we're going down for making decisions. So hospice is quite a bit more formal. So with Medicare, the requirements for hospice are that we have one specific diagnosis that we think will lead to the patient's death within 6 months. We never can know if that's accurate. So we have people who are on hospice for 2 or 3 years. That's not uncommon. But every 6 months, we have to say, and they ask the providers, do we think that they have more than 6 months? And if they don't, then we can consider hospice. Hospice is now focusing on that one diagnosis. So if you have CHF, if you have COPD, or any of the one diagnosis that has you on hospice, and we focus only on that disease. We don't focus, we do focus on family and mental health, but we focus on relief of that disease, expecting that it's going to cause death. So that's where the difference between those is we don't really have that wiggle room. Like, we have decided that we're not going to continue care anymore. We're only going to do things. So we wouldn't do any pain relief surgeries. We would, if they get a urinary tract infection, if we don't know, sometimes we won't treat it. If we do know, then, it's the patient's choice, because they may have said, last time I got a UTI, it was okay. I was really tired. I went to sleep, and that wouldn't be a bad way to die. So you have those discussions ahead of time. You make that plan ahead of time. And so if that occurred, you would probably not make that choice to treat other things. Yeah. Does that make sense? Do you have questions about that?
No, it makes perfect sense.
Okay.
And it's in our last episode, which I know you haven't seen yet because we just did it yesterday. We talked about longevity, living a longer life versus living a comfortable life, and what do you want to do? Because a lot of times, if you want to live that longer life, you're going to have that more invasive stuff that you were talking about.
Although more studies now, like later studies, are showing that depression is so significant in longevity that, we start to have to weigh that as a factor. Because we always think maybe getting all the best care would be the best, but the best care comes at a high cost. It's very stressful, it's very traumatic. And so sometimes those will shorten life more than not doing treatment. So I wouldn't say black and white now that you live longer if you're not on hospice. I wouldn't say that anymore. It's a gray area.
I could see that mental health playing a big part in that.
Yes.
Yeah.
Okay. Oh.
Well, will you also share your experience with the talk? So when you, let's take the example, well, in either instance, whether it's hospice or palliative care, I mean, you're talking about some serious conditions with the family members. And so that involves discussions that need to be had between the patient and their family. Would you see this as being initiated by the patient, the family, or you?
Yeah. So usually, almost always, it would be initiated by me.
Mm-hmm.
So I saw patients in their homes. I had, a set number of patients that I dealt with all the time. So it was like my patient subset. So I got to know them very well. I'd go to their houses. After a while, you've talked to everybody in the family because, everybody will call you. And I was really big on being very open and transparent. So you just get to know these people after a while. And there would be a point where you realize that what the patient's feeling is not the same as what the family's feeling. Like the patients frequently will talk to me privately, like, I wish they wouldn't do that. I wish they wouldn't fuss about that. I wish they wouldn't worry about that. And then I would see the family, they'd come to me after the meeting and just worry about everything that, mama had said. And so when I started to feel those inconsistencies, when we were struggling to make decisions, when we had to start making decisions very frequently, that's another one. Like if, we have to have a lot of these like mini talks of, do you want to go to the hospital? Do you not want to go? So I'd start watching for those signs. And then I would usually talk to the family and set up a time. So I'd say, hey, I want to meet everybody who's involved. I want everybody to come over and I want to talk about her plan. So, we're not deciding hospice or palliative. We're talking about just the plan, the path that we're going to take. We've got options now. Which road are we going to start going on? And so, yeah, I definitely would say that I initiated those.
Mm-hmm.
Wow. And I find it, well, when my father passed, we were all united behind my mom. Whatever my mom wanted to do, that's what we did. But I know that's not always the case.
It absolutely is not always the case. So I think an example is, I think this is a bad example. This is a way that it went poorly, and I think it's really where I learned the importance of the talk. So I had a patient who, and this can get into whole legal stuff. It's a really interesting legal topic, but the patient, I was a new nurse practitioner. It was one of the first patients that I started seeing. The first one that, this is the first time this really happened. And I went into her house and she just wasn't quite safe anymore. It wasn't unsafe, but like the house started smelling like dog urine. The stoves get left on. You can just see a decline, right? So I noticed this decline, but I was a new nurse practitioner and I was uncomfortable with this. I didn't know to really push for this. I didn't know that I really needed to get the family involved and have this conversation. So I waited and I waited and I waited. And then we got to a point where she was dangerous, for sure. Like black and white dangerous, can't walk away. I think one time, like I walked in and she had the stove and like it was dangerous. I don't even remember what happened, but it was dangerous. Like I walked in, it was like, okay, no, I can't do this. And like obviously you are not well. You're in danger. So at that point though, this is where I say the legal stuff gets interesting, is this woman is not able to make competent decisions. She has declined so much that we lost the opportunity to have her involvement in the care. So I learned to start this stuff early, early, early. And then, we start walking down that path and we can gradually get on that path. But, that's where we start going. And the more involvement we have, the earlier, the better outcomes. I found that patients who did palliative care had more favorable outcomes in the end when we talk about did their death go like they planned. Like if you wanted to be at home, if you wanted to be in the hospital. So if you do palliative care, if you start that early, then we can include everybody in that. that conversation. So I just learned that first time with that woman that there's more of a sense of urgency like than you'd think, because it's not necessarily when they die. It's not anywhere close to when they die. It's when they lose competency. So yeah, so now I get the families involved, or I did get them really early. Lots of transparency, yeah. So when I would start to see that the families were starting to have inconsistencies, or like maybe another reason to start the talk would be like a sister would call me, and then another sister would call me, and like they'd have different opinions. Um, and so black and white, you talk about your mom and everybody stands behind your mom. Black and white, the law requires that I listen to the POA. So if it doesn't matter how many people are involved in this care, that there has to be one speaker for the family, and that speaker is the power of attorney. So that's I will only listen to that person. Like that's the only person I'm going to let direct my care. So sometimes it's really important that we have a meeting with all the family members where we sit down and discuss what we all want. Um, yeah. And a lot of times the patients themselves were really thankful to have this talk. They really liked this. Like I said, when I was new, I didn't have the talk because it was awkward, and this is what's happening here. They don't have the talk because it's awkward. But it's usually just so much more peaceful. And now everybody's aligned, and whether or not you agree or whatever, you know what your family has decided. And so you just start coping with things better.
Mm-hmm.
Yeah. So you kind of answered our next question, which is great. No, it's great. So I have a different question for you. Are you ready? Are you sitting down?
Yes.
Okay. So
Yes.
I'm gonna catch you off guard. Have you had the talk with anyone
About what?
about
What
your
do you
end of
mean?
life planning? About
Oh,
what you want?
So I'm in an interesting situation because I am divorced,
Mm-hmm.
and I'm not extremely close to my family. Although legally, if something happened to me, I know that it would go to my next of kin. So it would be my parents. And at this point, I am okay with the fact that it would be my parents. So I feel like they would take care of my interests. My dad is a doctor. He would make sure that I got the best medical decisions. So I haven't, but I have really chastised myself a lot for not having an advance directive.
Yeah, that's how this all started for us. We were going on vacation, and we're like, when's the last time we did this stuff?
Mm-hmm.
And then it's like snowballed after that, because where I work, a lot of people don't plan for this, and
People don't.
it's really hard, especially on the students, because I'm a teacher, and just seeing the wear in their faces and how they lose focus because they feel hopeless.
Mm-hmm.
And yeah, that's why we're trying to do this. So sorry to catch you off guard, but
You're okay.
I saw an opportunity. I was like, I'm going to jump on this opportunity.
And
Also, I said I felt okay with my dad being my POA. I have a boyfriend now. We've been together for a while, and we have started talking about making him like a medical POA. So, like, while I would still prefer my dad does all the financial stuff and protecting my children, I would like to do. You can kind of piecemeal all of this stuff out, and so I'd like to do a POA with him.
Yeah, we used a local attorney here in Bernie, and we actually chose my son, who's living with us right now while he's finishing his schooling. He's not the eldest, but he's here, and the proximity of him being here was a big factor in us choosing him. So, all right.
I wanted to circle back real quick on something that was said, because at the very beginning you talked about the mental wellness of all of this, the mental health part, and honestly, I think that's the first time I've really heard that. And the thing I don't recall reading that part in the
That
book.
wasn't in his book, I don't think.
We just read a book about having the conversation. And I don't think I've heard it anywhere else on any other podcast that I've listened to or researched. So I think the point of you bringing out the mental health of this whole process, I wanted to make sure I said that out loud and reminded myself of that, because I think that part is very important, especially when Santiago, you just said about your students losing focus, and that really brought it forward to me. So I just wanted to reiterate that.
I have a, oh, sorry, what?
Go ahead.
I have my personal experience with this is what led me actually to become a nurse. So this situation that you're talking about right now is why I'm a nurse. So when I was 19, my best friend got liver cancer, and she lived for 4 months after the diagnosis. So at this point we have me, her fiance, she was really close to her youth director, and then her mom, and we are pretty much in there the whole time. Like she always had someone with her, and the nurse was different than the other nurses. The nurse who took care of her, and I called her eventually and said, "Oh, you made me be a nurse," but she Sarah a lot of times wasn't there, right? Sarah was going to die. And Sarah was, asleep for a lot of it, or delusional, or she just wasn't there for a lot of the time that we were there. And the nurse that took care of her really took care of me and her fiance. There was lots of counseling, lots of talking, because honestly, Sarah's the patient, sure, but we were going to live. We were patients too. And Lynette she took care of us. And so I think that really was why I wanted to be a nurse. It was like, we don't see all of the issues that are going, like, it's not just that patient. And in the hospital and all those situations, it's only the patient. But with, these other ones, we can start to realize that the family are patients too, and their mental health and everybody's mental health is so important, because they're patients. They're a person who is in the medical community because they're going through a trauma and a loss. So
I know there's a stigma, especially with the males of the species, that they get help sometimes. And I think for me, having been to counselors through traumatic events in my life, it really helps out a lot. And in our last episode, we talked a little bit about planning now while the emotions aren't high, and understanding that the decisions you make right now with a clear mind will benefit you in the long run. Did you see that when people came in with a clear plan, that everybody's mental state was a little
I think
easier?
that's when we go back and say that palliative care or early palliative care leads toward a better death outcome, but more following their outcomes. So very, very rarely, almost never, did I have anybody who came to me with a plan. But I, as a provider, knew it was very important. I understood what you were saying when they didn't. And so, yes, like having a plan before, knowing, getting used to it, talking it out, make death so much better.
And that's actually that's why we
That's what we're trying to do.
Started the podcast to try to bring this, not to be so awkward. So
yeah, well, it shouldn't be. It shouldn't be. And it was what I found so many times was that the patient wanted it. The patient knew. I mean, we all know we're gonna die. Like we've been ready for this our whole lives. Like we know, and you can't be like delusional. If you're 89 and you've got lots of diseases, like you're going to die, and they know that, and they're a lot of times more prepared than everybody else. And so, yeah, having that talk would make everything so much better. That's why I said with the lady that I messed up and I didn't involve myself earlier, because then we did have to make those decisions when, I was in her house and I wasn't safe to leave. So we had to make emergency decisions when I learned at that time to start the intervention so much earlier.
Yes. Thank you for that. Thanks for sharing.
Let's see here. If you can share something with the audience that you think everyone should know, what would it be?
So I know, I guess I would have like a couple. It's not the point. So I don't know. I'll give you two.
Okay, give us it.
One
Perfect.
is, I would say, talk. Like, talk. Talk to each other about this. This is not, nobody's hated these conversations after. Like, they're good conversations. Nobody walks away. I mean, you walk away sad, but you walk away with a plan. And that always makes you feel better. You know, you have a plan. You know how we're going to handle this. So talk. That's just be blunt. What do you want to do when you die, Mom? What do you want us to do? How do you want to go down this? And they'll talk to you about it. And then second, I would say, and this is sad that I have to say this, but I would really research the law, to be an advocate for yourself. Because so we talked about the difference between hospice and palliative care, and so many times. So I was primary, right? So hospice is like a specialty. It's like a cardiologist or something. So like pulmonologist, whatever. Hospice is a specialty. So we, as the primary care, would refer our patients to hospice. And we had a great relationship with the hospices. Like, we knew them, and anytime the upper management heard about this, they would intervene. But very frequently, when we would put people on hospice, the hospice would say, "You don't need another doctor." And so they would say to us, "Okay, we've got hospice now. They're taking care of everything." But what they forget is they're taking care of one disease. And so I would make sure keep yourself informed. Know that you don't have to switch to only hospice. They'll tell you that. They tell you that you do, and that's incorrect. And I know why they do it, because it's a very subtle and hard thing to explain. And, nurses who haven't been there for a long time, they say this stuff to the patient. But just know you're right. Know what you can do and what you can't. You need to, and then make sure you have everything in order. So that would be, I guess, how to do it is you go to the Texas board has or the Texas state has a whole bunch of documentation and stuff ready for you. So look through those. So talk about it and then look through those and stepwise go through it.
Okay.
Cool. Well, thank you, Robyn, for being our guest today.
Thank y'all for having me.
Yeah, it's been very informative. I've learned a lot. So, yeah.
You gave us some more things to think about in our planning. So we appreciate that. And I think, just to reiterate one thing that you said, make sure that you review, and don't stop the conversation after one conversation.
Oh, absolutely. Yes. No,
So,
don't. Just talk all the time about this.
Yeah.
It's not as awkward as it sounds.
Well, yeah, and sometimes you change. So we change. So to circle back on our essential question, after we've had our discussion, I'd like you now to think about, how do you know if hospice is good for you or your family? And it might be good today, maybe not tomorrow. So it's something for you to think about. Okay?
Well, until next time, remember, every chapter you write today shapes your legacy tomorrow. Thank you for joining us at Thoughtful Planning.
All right.
Goofy.
Stop recording.